check here. Here I came down the inguinal ligament, and I came here. I may just palpate real quick here because I'm suspecting that she's going to have an anterior head. Sometimes what you'll find is that it may be resting anterior here, so I'll feel more tension as I come over the hip here. So I come right off the pulse up in here. It may be right there. I feel like it's maybe a little bit more tension there. And sometimes you'll feel some tension here. So just get a sense of just kind of what I would feel if I think she has an anterior centered head. So hip range of motion. I'm here, SI joint and nominator moving. So what I need to be able to do is to get full hip range, come here, I'm going to stabilize SI joint, or I'm sorry, the nominate, and come forward. So if I'm here, she can go all the way here, but a lot of that is pelvic and lumbar motion. So as I do this, my thumb will sit on the anterior SI joint. I'll stabilize here in her size, and she's got a lot of range. Probably more so than other people have, but right about there. So you have to stabilize it, do it to get the end feel.
Are you depressing?
Yes.
Okay.
Because right about here, see what happened. You tell me when.
Right
Late,
there.
right there. So that's late. So if anything in the back of my mind, I go, okay, she's got a pretty expanded zone there, but I wouldn't consider it abnormal or pathological. I just kind of know it, log it in the back of my mind that she's got a fair amount of mobility before I feel SI joint and hip come in. That could be part of her strategy. We'll look at some videos of Jordan doing this, who's very good. So here I can just get a sense of the same thing here. I can get an out flare here. So I'll feel the innominate. So here, R1. Tissue bind. And it should be kind of a springy infield. Shouldn't be jammed. Sublux shouldn't be hypertonic.
Are you cupping around the ASIS?
Yes.
Okay.
I'm using this to she's small enough where I can probably just stabilize with my thumb. I don't need a full hand. Like you, I probably need a kind of a little bit more of a hand grip. And you have a much more muscular end feel. So here, and see how I use a lot of my body when I'm with people. It's different when you're female, but I use it because it gives me a lot of control. So I can be here and do it, but you get a sense of when I get my shoulder on it, how much more control I have. So I tend to use a lot of my body. You do what you're comfortable with. But the more contact I have, the better. If I'm here doing it, feel how loose that is.
Yeah.
Your body wants to control it. So I want to get a sense of when she's toning, how much tone we have. So I get here, R1-ish, and then the ligament tightens up. Okay, and then the nominate moves. So all this last 5-10 degrees is me kind of pulling the nominate in and its motion elsewhere. So if I stabilize, there's my end feel. See how I don't get an end feel here?
Yeah.
So by stabilizing the nominate here, I come to my end feel right there versus I just kind of keep going with it. So that little bit of stabilization is important. I'm sorry?
I was going to say, I feel like my hip coming up.
Yes. Yeah, you'll feel that thing. So the idea is that I look at this, just getting a sense of how much is hip motion versus what is combined hip, pelvic, lumbar motion. Just kind of curious. So this should be interesting. First, I'm just gonna get it. Like I know I'm interested in this hip, so real quick, just looking at femoral head centering. If I bring her up here, sometimes what you'll feel is as you get down that low angle, the femoral head will kind of ride forward. So I just want to get a sense of that's happening. Here, and what I may lose is it may be tighter on this one because the femoral head isn't centering. So it's not bad. Feel. Again, normal end feel, just take up the slack in soft tissue. If anything, they would probably look soft. So internal rotation. Internal rotation is usually my first sign if I have a sublux tip. I call it the Euphor, but I like to think of it as if the hip is lacking posterior glide. It's anteriorly translated, and it won't posteriorly glide with extension, internal rotation, the end part of gait. So here, stabilize here, just get a sense of it. Like what'll often happen is they'll stop right about here with a harder end feel. It'll just kind of stop here and it'll bind up, like okay, I'm compressing into the labrum. Like there's something's being kind of compressed and squeezed, almost like an SI joint feel in a way. Versus here, so I can check it if I have it, I can bring it at different angles and look at it. And we'll look at Jordan do it, because Jordan's the one who did some of the research on it, who did this video. Okay. Just get a sense. So good range. Excessive matters to me too, because I think her R1, you let me know when you feel R1. So it's a long range, a long way to go before you hit an R1. And then, got a bit more. The other thing I'll watch for too sometimes, depending where my lever is I'm going through the femur, because some people with all this range or tightness, as I get in here, you'll see some compensatory rotation in the knee. So some people get out here, and then all of a sudden you feel that knee joint laterally rotate. I'll pay attention to make sure, do I have something there? Do I need to look at it down there? But it happens sometimes just with the mechanics. So there, my range there. So a lot of range in this hip. It's not currently subluxed. I know it lives anteriorly and standing, and she can't control it, okay? So I know, okay, I want to account for it's probably going to be a motor control issue or hip centering issue that we want to work on with her. Let me get you lying on your belly. Extension, I'm going to stabilize usually through the sacrum and the pelvis. So I'm going to take it, I'm going to kind of grab on here, kind of glide down. Because here, pelvic, lumbar spine into there. So you see where if I have a tight hip, and the hip tightens, I'm going to go very quickly up into this region. So here I'm going to stabilize down, and I'm more in the sacrum. I'm going to come up and feel, okay, R1, and then in range. Anything more goes right up in the back, so your back move. So it's okay if I go too far first. Sometimes you will. That just helps you set your game. So it's okay if you go far, and sometimes like I did with the feeling the pelvis with the manipulation, it's nice to feel what is wrong. So you get a sense of what is right. So if I bring her all the way up there, okay, that's into the back, and she's gonna go, oh, my back, if she is the patient we had this morning. So I know that, okay, if I stop here, and I block the forces from in the back, that back patient case from this morning, like, okay, no, that feels okay. I don't really notice it, because I'm blocking the extension moment into the back. So I can assess the hip's ability to move. That idea of normal motion, tissue tightening, and then take up all the slack. So it's like I often talk about being a logarithmic tightening. So I got R1, and then I get that tightness, and then it's like a curve that goes up like that. So there's not much range after there. So I'll go all the way up into the back. And probably that may be helpful with is seeing that how quickly one leg goes into the back versus the other. Because my model that, okay, this hip maybe, this is this functional hip and it's got more mobility, then she should have more place. You tell me what you feel as we get in here. Right there. R1?
Yeah.
Okay. So what I feel like if I have to stabilize more, do I have more play there and here? Does the infields feel different to you?
Yeah, I feel like this one has been expanded.
Expanded neutral zone. Yep,
Yeah.
it does. So that's why it's got to slow it down for me and be subtle. Because a lot of what I treat is not, okay, well, she has 15 degrees or 20 degrees of hip extension. This is where her problem lies. And she has this expanded neutral zone. I just kind of keep going. I hit R1, and I've got an elongated R1. So the tissue doesn't wind up quite as tight because it's kind of slowly breaking down and lengthening.
Can you quick summarize what we found in standing with her? Just 'cause
She had a loss of, it was femoral head control in standing. So when she,
anterior, yeah.
yeah, her hip was anterior, and when she weight shifted, she had basically early femoral head internal rotation. So she wasn't centering it properly. She couldn't keep it centered in the acetabulum when transferring her weight to her right leg. When she was running on Friday, she had a lot of anterior hip pain when she came in after that class. So it just feels kind of tight through her anterior hip. So right now what we're seeing is that, okay, increased kind of neutral zone and extension, and even the R1 to like an R4, that end range zone, has a bit more elasticity in it. So as there's like laxity, or start to get this little bit of a breakdown. You may be able to see it in the log roll test. You saw when I rolled her over, I didn't talk about it, I quickly rolled her leg. I don't find the log roll incredibly useful as an aha moment. I compare it to other stuff. And I'll often find that with that, the log roll will feel a lot looser. The leg just kind of flops around more. Whereas the normal log roll, the ligaments tighten up and spring your leg back in. So, not definitive for me, but I like to kind of do it and compare it. I'll also use this one as my definitive subluxed hip one, because I can compare internal rotation moment equally on both sides. and you can see kind of where it goes. And she's fairly equal here. I don't really see much difference. Now I can kind of come down in here and see, is there a difference in the end field? Maybe subtle there, but not really significant. End range extension, internal rotation quadrant. It's easier to do if I come across here, because as soon as I pull up, I internally rotate her hip. Think running, walking. Internal rotation, extension, deduction. Tight in here. This often will be a tight quadrant in maybe early hip OA. There are certain hip quadrants, there are different ones people define. Their research on it's kind of iffy on hip quadrants, but you often find that this may be lost early with hip OA. Or definitely if you're thinking that guy who's sitting too much, and now he's in his late 40s or 50s, he'll be lacking this because of the chronic sitting. And then the compensatory motion comes in the back. So stabilizing sacrum. I can do it again here. It's just because I'm taller, it's easier. I can internally rotate the leg, adduct it, and extend it in that internal quadrant. This, I think, is the closed pack position. Is internal rotation, extension is considered the closed pack, but there's not much closed pack in there. Yeah, got a lot of mobility there. Okay. I think I'm missing anything in here. So I got internal rotation, adduction, extension, and I can do external rotation out in here and just check the quadrants. This is the ovoid motion of the hip. When Jim talks about quadrants, quadrant screening is something where you take that joint through its big ovoid motion or through its ranges, and you're really looking to see if you provoke anything. So when you talk about quadrant testing, he's saying, okay, if I take you through like an elbow quadrant, which is here and here, where I have supination, flexion, abduction, supination, flexion, adduction, I think, and same down in here, I can take it through these quadrants and see I'm taking the elbow through all its arcing motions. Do I reproduce pain or symptoms in any one of the quadrants? If I do, then I can go look at what's specific to that quadrant that may be causing the pain. Let's get you laying on your back. You take hip. And again, you can tell here that her hip's going to look different than my hip. As I go through it, so you can test it here. But with all this laxity, I know that, okay, I can reproduce pain in her hip. Which again, at this point, I feel like I'm trying to pull, like, it's like basically there's just so much laxity, I can put a lot of stress and torque in it. It's not really tightening up. So pain provocation here in this hip or the other hip, necessarily wouldn't surprise me. It's how relevant is it to her meaningful complaint. Her meaningful complaint is probably anterior hip pain is limiting my running and walking afterward, correct?
Yeah, I do feel like my hip is forward even sometimes, like when I wake up, I stretch out before going to work.
Yeah. What concerns you about this?
Over time. Just because, well, fun fact too, I started noticing my big toes, I feel like I have increased sensitivity to them. Like when I touch it, it feels different compared to everything else. So I feel like I have like an L5 problem.
Both of them?
Yeah.
Yeah, probably not likely, which is good.
Okay.
Because then you have, like I call it equine or something, push bone both of them. Or MS.
Well,
Now
and
you're-
then
now you're
I
scared.
played soccer. Well, I played soccer too, and so I have like chronic ankle sprains.
Okay.
So I feel like that's part of the problem too.
Yeah, it could be a couple things, especially if you start running. So part of it is understanding her meaningful complaint. What is her major worry about this hip? I mean, I won't tell her about how her trying to tell me. Your major worry is my hip breaking down? Am I getting something wrong? Do I have a labral tear?
Yeah.
Those are probably your fears that she has. So somewhere in there, I want to talk to her about how this is a very common hip problem and stability thing I'll see. I see a lot of runners as they get later in marathon season. You have players you're playing soccer, and soccer does put a lot of stress, on the labrum, so we see it, but it doesn't necessarily mean that, okay, you're gonna need to go to surgery. It doesn't, it's not the pain level that I see that. There's a lot of things that we can do, like working on hip centering, we can work on your running strategy, stride length. There's many things that we can do to probably take some of the stress off of this anterior hip. But it's not an uncommon thing to see. You're a very mobile person. And I always say that I'd rather see somebody come from the CrossFit studio than the yoga studio. Because the CrossFitter is going to be easier to fix than the hypermobile person from the yoga studio. So we're going to work on controlling this range of motion. What we're probably going to do is we'll look at stride length and your running, shorten your stride, and quicken your cadence. There's many things we can do to kind of take some of the stress off the anterior hip. So I'm going to put them at ease when I feel it's appropriate with that. So I want to understand what's their meaningful complaint. Okay, I got pain with running. but I also understand what is their psychological factor in there, what is the thing that's stressing them the most about this, the emotional component, and making sure that throughout this I'm addressing the emotional component and the meaningful complaint. Because they're usually pretty standard, we all have it. It's like, boy, if he's a 50-year-old runner, he's thinking, man, do I have arthritis? Is this it? Am I gonna need a hip replacement? Because I feel my anterior hip when I run, it's sore. You know, you gotta really kind of put them at ease of what are the facts about it and understand their psychology. And that's kind of gonna improve your buy-in and how well they do. So those are two meaningful things to kind of see as we do this. Okay, lost my train of thought on what's next. Okay, internal quadrant. Who isn't painful in this? Maybe you, because there's no end feel. We're all different. We have different hips, so we're from different parts of the world. Our hips are gonna be a little bit different in what they allow us to do. Here, there's no rounding in the acetabulum. Like, I don't feel like, you know, sometimes you get in there and you feel you get a button and you go, oh, it pinches. And you get it, because you have that acetabulum, the femoral head, you're driving it into it. So it's very common to get this in here. But this is a very kind of empty end feel in here.
So that's a quadrant, or are you doing a scour?
It's a scour, but
yeah.
the quadrant could be just me winding it in here
Okay.
and here. So the scour test isn't all that different. It's just a matter of, I mean, wind in here, this flexion quadrant. These ovoids, with the hips and the shoulders, the ovoids of motion. It's what is the outer ovoid of motion in the hip allow me to do? Is it provocative? So when I bring this hip out here, is it provocative? So right about in there kind of comes into be your Faber's position, right? But the ovoid of motion is going to be here. Do I feel anything abnormal? Do I feel an abnormal blip? So if she has a labrum potentially that's irritable or there, do I feel a bump in any of these? Because commonly they're going to be pretty tight and bound in right here. The subluxed hip will often be pinchy in here because it's that internal rotation posterior glide moment of the femur that they don't like or it doesn't want to do. So it puts a lot of stress on it as I get into that position. Resistance testing, we did resistance testing for all the muscles around here. Now, let me try this here. Go ahead and hold here, let me pull. She's pretty solid there, I think it's pretty good. But what I look for there is that if she wasn't, then I would cue her, can you stabilize pelvic floor? Good. And now it's more solid. She has a stable base to drive from. So if she had failed load transfer through, was her SI joint check out okay? Was it just the hip?
SI a little bit.
A little bit, okay. So yeah, so if she had failed load transfer in there, I would likely find this positive because she may not be firing the muscular system fast enough. So if I don't cue her, now she knows what she's doing. But if I didn't cue her, then she may have that. And if I can get her to stabilize there, then I know that, hey, stabilizing that will help center her hip and she'll be stronger. Stop it for a second, I want to change.